Good morning, guys. Today we talking about acute appendicitis, and it is most common disease in the surgery, in the general surgery, and this is the monkey of all disease. Why it is the monkey of all disease? I will answer you in the lecture. Appendicitis is inflammation of the veriformix appendix. Appendix, hollow organ located at the tip of the cecum, usually in the right lower quadrant of the abdomen. However, it can be located in almost any area of the abdomen, depending on if there were any abnormal developmental issues, including midgut malrotation, or if there are any other special conditions such as pregnancy or prior abdominal surgeries. Embryonically, the appendix develops embryonically in the fifth week. There is a rotation of the midgut to the external umbilical cord, with the eventual return to the abdomen and rotation of the cecum. This results in the usual retrocecal location of the appendix. Disease. It is often a disease of acute presentation, usually within 24 hours, but it can also present a small chronic condition. If there has been a perforation with a contained abscess, the presenting symptoms can be more indolent. Function of the appendix. The exact function of the appendix has been a debated topic. Today, it is accepted that this organ may have an immunoprotective function and acts as lymphoid organ, especially in the younger person. Other theories contend that the appendix acts as storage vessel for good colonic bacteria. Still others argue that it's a mere developmental remnant and has no real function. I think that it is immunoprotective function, and I see the patients where we have any problem just because they have a immunosuggestive situation. Etiology. The cause of appendicitis is usually an obstruction of the appendiceal lumen. This can be from an appendicolite or some other mechanical etiologies. Appendiceal tumors such as carcinoid tumors, appendiceal adenocarcinoma, intestinal parasites, and hypertrophied lymphatic tissue are all known causes of appendiceal obstruction and appendicitis. Often the exact etiology of acute appendicitis is unknown. When the appendiceal lumen gets obstructed, bacteria build up in the appendix and cause acute inflammation with perforation and abscess formation. One of the most popular misconceptions is the story of the death of Harry Houdini. Few words about this one. After being unexpectedly punched in the abdomen, the rumor goes that his appendix ruptures, causing immediate sepsis and death. The facts are that Houdini did die from sepsis and peritonitis from a ruptured appendix, but it had no connection to him being struck in the abdomen. It was more related to widespread peritonitis and the limited availability of effective antibiotics. The appendix contains aerobic and anaerobic bacteria, including Escherichia coli and Bacteroides saprophytes. However, recent studies utilizing next-generation sequencing revealed a significantly higher number of bacterial phyla in patients with complicated perforated appendicitis. Appendicitis occurs most often between the ages of 5 and 45, with a mean age of 28. The incidence is approximately 233 per 100,000 people. Males have a slightly higher predisposition to developing acute appendicitis than females, with a lifetime incidence of 8 and 6% for men and women respectively. Approximately 300,000 hospital visits early in the United States for appendicitis-related issues. The pathophysiology of appendicitis likely stems from obstruction of the appendiceal orifice, how I told before. The background etiology of the obstruction might differ in the different age groups. While lymphoid hyperplasia is essential, this results in inflammation, localized ischemia, perforation, and the development of a contained abscess of frank perforation with resultant peritonitis. This obstruction may be caused by lymphoid hyperplasia, infections, fecal-itis, or benign or malignant tumors. When an obstruction is the cause of appendicitis, it leads to an increase in intraluminal and intramural pressure, resulting in small vessel occlusion and lymphatic stasis. Once obstructed, the appendix fills with mucus and becomes distended, and as lymphatic and vascular compromise advances, the wall of appendix becomes ischemic and necrotic. Bacterial overgrowth then occurs in the obstructed appendix, with aerobic organism predominating in early appendicitis and mixed aerobes and anaerobes later in the course. Common organisms include Escherichia coli, Peptostreptococcus, bacteroids, and Pseudomonas. Once significant inflammation and necrosis occurs, the appendix is at risk of perforation, leading to localized abscess and sometimes frank peritonitis. The most common position of the appendix is retrocecal, how you see in the picture, while the anatomical position of the root of the appendix is mostly constant. Tail positions can vary. How you see, it can be pre-ileal, post-ileal, sub-ileal, paracecal, and others. Possible positions include retrocecal, subcecal, pre- and post-ileal, and pelvic. Microscopic findings in acute appendicitis include the proliferation of neutrophils of the muscular propria. The degree and extent of inflammation are directly proportionate to the severity of the infection and duration of the disease. As the condition progresses, extraappendiceal fat and surrounding tissue become involved in the inflammatory process. How you understand? I don't understand histopathology. I don't will ask about you the histopathology, but somebody who won't be a histologist, yeah, you need to know this one. History and physical, it's more interesting moment in this presentation. Typically, appendicitis presents as an initial generalized or periumbilical abdominal pain that localizes to the right lower quadrant. How you see in the picture, you see the umbilicus, yeah, and the right region always will have the appendicitis. But we have some problem, guys, about monkey. Initially, the visceral afferent nerve fibers at T8 through T10 are stimulated, leading to vague centralis pain. As the appendix becomes more inflamed and the adjacent parietal peritoneum is irritated, the pain becomes more localized to the right lower quadrant. How you understand the pain in the spine will give the pain in the right region, and it always nervous surgeons, because sometimes we see the patients with the appendicitis, yeah, but it is just a spine pain. Following symptoms: anorexia, nausea, vomiting, fever, diarrhea, generalized malaise, urinary frequency or urgency. Uncommon presentations. Some patients may present with uncommon features. In these patients, the pain may have woken the patient up from sleep. In addition, the patients may complain of pain while walking or coughing. Pain upon passive extension of the right leg with pain patient in the left lateral decubitus position is known as psoas sign. This maneuver stretches the psoas major muscle, which can be irritated by an inflamed retrocecal appendix. Patients often flex the hip to shorten the psoas major muscle and relieve pain. Physical exam findings are often subtle, especially in early appendicitis. As inflammation progresses, signs of peritoneal inflammation develop. Signs include right lower quadrant warting and rebound tenderness over McBurney's point. You will see it after. Rovsin sign, right lower quadrant pain elicited by palpation of the left lower quadrant. Dancy sign, increased abdominal pain with coughing. History. Other associated signs such as psoas sign or obturator sign are rare. The time course of symptoms is variable but typically progression from early appendicitis. at 12 to 24 hours to perforation at greater than 48 hours. 75% of patients present within 24 hours of the onset of symptoms. The risk of rupture is variable but is about 2% at 36 hours and increases about 5% every 12 hours after that. Several practical scores have been defined to facilitate the prompt diagnosis of acute appendicitis, mainly based on the history and physical examination, accompanied by laboratory tests and imaging measures including abdominal ultrasonography. Accordingly, evaluation of patients with suspicious signs and symptoms suggestive of acute appendicitis has been widely undertaken with Alvarado criteria since 1986. Alvarado criteria. The highest score on Alvarado criteria is allocated to the tenderness in the right iliac fossa, leukocytosis, and each of the other predicted symptoms, including migratory right iliac fossa pain, nausea and/or vomiting, and anorexia, hold 1 score. Moreover, positive finds in the remaining indexes of physical examination, including fever and rebound tenderness in the right iliac fossa, would hold a similar score of 1. Evaluation. The emergency department physician must refrain from giving the patient any pain medication until the surgeon has seen the patient. The analgesics can mask the peritoneal signs and lead to a delay in diagnosis or even a ruptured appendix. Laboratory measurements, including total leukocyte count, neutrophil percentage, and C-reactive protein concentration, are requested to process with diagnostic steps in patients with suspected acute appendicitis. Elevated white blood cells count, with or without a left shift or bandemia, is classically present, but up to 1/3 of patients with acute appendicitis will present with a normal WBC or less WBC, how I see in my practice. There are usually ketones found in the urine, and the C-reactive protein may be elevated or may be not elevated. A combination of normal WBC and CRP results has a specificity of 98% for the exclusion of acute appendicitis. Moreover, the WBC and CPR results have a positive predictive value to differentiated, uninflamed, uncomplicated, and complicated appendicitis. And I please you remembering about uninflamed, uncomplicated, and complicated appendicitis, because in this lecture you don't will hearing something about this one, but you need to know about all of these definitive. Both increasing levels of CRP and WBC correlate with a significant increase in the likelihood of complicated appendicitis. The possibility of a patient having appendicitis with both normal values of WBC and CRP levels is extremely low. The WBC count of 10,000 cells is highly predictable in patients with acute appendicitis. However, the level would increase in patients with complicated appendicitis. Accordingly, the WBC count of a coil and or above 1700 cells associated with complications of acute appendicitis, including perforated and gangrenous appendicitis. Appendicitis is traditionally a clinical diagnosis. Clinical, I repeat, because 90% of this diagnosis you will stay with your arm. However, several imaging modalities are used to proceed with the diagnostic steps, including an abdominal CT scan, ultrasonography, and MRI. An abdominal CT scan, how you see there, has greater than 95% accuracy for the diagnosis of appendicitis, and is used with increasing frequency, but not in Russia. CT criteria for appendicitis include an enlarged appendix greater than 6 mm in diameter, appendiceal wall thickening greater than 2 mm, periappendiceal fat strengthening, appendical wall enhancement, the presence of appendical lid, approximately 25% of patients. It is unusual to see air or contrast on the lumen with appendicitis due to luminal distension and possible blockage in most cases of appendicitis. Ultrasound. Non-visualization of the appendix doesn't rule out appendicitis. Ultrasound is less sensitive and specific than CT, but may be useful to avoid ionizing radiation in children and pregnant women. MRI, may also be useful for pregnant patients with suspected appendicitis and an indeterminate ultrasound. Classically, the best way to diagnose acute appendicitis is with a good history and detailed physical exam performed by an experienced surgeon. However, it is very easy to get a CT scan done in the emergency department. It has become common practice to rely mostly on the CT report to make the diagnosis of acute appendicitis. Occasionally, appendicitis are incidentally found on routine X-rays or CT scans. There you see a photo with ileoquine, iliac and appendix. In my practice, ultrasound we use just to find fluid inside the pelvic, and if we find the fluid and if we have any signs of appendicitis, we're talking about appendicitis and do the CT image. The major concern with obtaining an abdominal pelvic CT scan is radiation exposure. However, the average exposure with a typical CT would not exceed 4 mSv, which is slightly above the background exposure or almost 3 mSv. Despite the higher resolution of CT image obtained with the maximal radiation of 4 mSv, lower exposures would not affect the clinical outcomes. Moreover, obtaining an IV contrast abdominal pelvic CT scan in patients suspicious of acute appendicitis should be limited to an acceptable glomerular filtration rate equal to or above 30 ml per minute. These patients are at higher risk of developing appendicitis than the general population. These patients should be considered for prophylactic appendectomies. Studies have also shown a 10 to 30% incidence of appendiculitis present in appendectomy specimens done for acute appendicitis. Abdominal ultrasonography is a widely used and available primary measure to evaluate patients with acute abdominal pain. A specific index of compressibility, along with a diameter of less than 5 mm, is used to exclude appendicitis. On the contrary, several evidence, including an anteroposterior diameter of above 6 mm, an appendiculite, and abnormally increased echogenicity of the periappendicular fat, are suggestive of acute appendicitis. The major concern with using abdominal ultrasonography to evaluate the potential diagnosis of acute appendicitis are the innate limitation of the sonography in obese patients and the operator dependency to find the suggestive features. Moreover, patients complicated with peritonitis would hardly tolerate the graded compression. MRI. Despite the high sensitivity and specificity of MRI in the context of acute appendicitis, and identification the minor concerns with obtaining an abdominal MRI access. Performing an abdominal MRI is not only expensive but also demands a high level of expertise to interpret the results. Therefore, its indications are mainly limited to special groups of patients, including pregnant women in whom an unacceptable risk of radiation exposure is embedded. In the emergency department, the patient must be kept nil per os and hydrated intravenously with crystalloid, and antibiotics should be administered intravenously as per the surgeon. The responsibility for the consent falls on the surgeon. The gold standard treatment for acute appendicitis is to perform an appendectomy. Laparoscopic appendectomy is preferred over the open approach. Appendectomies. Most uncomplicated appendectomies are performed laparoscopically. Several studies have compared the outcomes with the laparoscopic appendectomy group and patients who underwent open appendectomy. The results were suggestive for a lower incidence of wound infection, decreased level of postoperative analgesic requirement, and shorter postoperative hospital stays in the former group. The main disadvantage of laparoscopic appendectomy is the longer operative time. Abscess. In case where there is an abscess or advanced infection, the open approach may be needed. The laparoscopic approach affords less pain, quicker recovery, and the ability to lower most of the abdomen through small incision. Situation where there is a known abscess from a perforated appendix may require a percutaneous drainage procedure, usually done by an interventional radiologist. Stabilizes the patient and allows the inflammation to subside over time, enabling a less difficult laparoscopic appendectomy to be performed at a later date. But these practitioners also start patients on broad-spectrum antibiotics. There is some disagreement regarding preoperative antibiotic administration for uncomplicated appendicitis. Some surgeons feel routine antibiotics in these cases are not warranted, while others give them routinely. There have also been several studies promoting the treatment of uncomplicated appendicitis solely with antibiotics and avoiding surgery altogether. Appendical abscess. In patients with an appendical abscess, some surgeons continue antibiotics for several weeks and then perform an elective appendectomy. When the appendix has ruptured, the procedure can still be done laparoscopically, but extensive irrigation of the abdomen and pelvis is necessary. In addition, the trocar sites may have to be left open. A significant number of patients with an impression of acute appendicitis can be managed with a laparoscopic approach uneventfully. However, several factors predict the demand to convert to the open approach. The only preoperative independent factor predicting the conversion during laparoscopic appendectomy is the presence of comorbidities. Moreover, a couple of intraoperative findings, including the presence of periappendicular abscess and diffuse peritonitis, are independent predictors of not only a higher conversion rate but also a significant increase in postoperative complications. While laparoscopic appendectomy has been widely used as the preferred approach for the surgical management of acute appendicitis, in many centers still open appendectomy might be selected as a practical choice, specifically in the management of complicated appendicitis with phlegmon and in the patients who are subjected to the conversion from the laparoscopic approach, mainly due to the potential issues related to poor visibility. Several other alternative surgical approaches, including natural orifice transluminal endoscopic surgery and single incision laparoscopic surgery, have been introduced recently. The idea of utilizing a flexible endoscope to enter the gastrointestinal or vaginal tract and consequently traversing the mentioned organ to enter the peritoneal cavity is an interesting alternative for patients who are considerate about the cosmetics aspects of the procedures. It has been later tested with successful performance of transgastric appendectomy in a group of 10 Indian patients. The major potential advantages of appendectomy with nodes are avoiding scars and limiting postoperative pain. Regarding the limited number of patients who have been under nodes, appendectomy, a detailed comparison of postoperative outcomes is still impossible. Hence, the major drawback with performing this technique is the demand to hybrid with the laparoscopic approach is to provide adequate retraction during the procedure and to confirm the closure of the entry site. As a surgical technique, seals for an appendectomy is performed with an incision in the umbilicus or a pre-existing abdominal scar. Potential advantages of seals include a decrease in postoperative pain, wound-related post-procedural complication, and consequent shorter periods of sick leave. However, up to 40% of patients are still converted to conventional laparoscopy at some point during the procedure. The major disadvantage of seals for an appendectomy is a higher long-term complication related to incisional hernia. Differential diagnosis includes Crohn's ileitis. Before I tell about this one, I want to tell you that in our hospital we always do laparoscopic appendectomy, and maybe in months we do open surgery because it was a very hard situation. Crohn's ileitis, mesenteric adenitis, inflammatory processes in the cecal diverticulum, Mittelschmerz, salpingitis, ruptured ovarian cyst, ectopic pregnancy, tuber-ovarian abscess, musculoskeletal disorders, endometriosis, pelvic inflammatory disease, gastroenteritis, right-sided colitis, renal colic, kidney stones, irritable bowel disease, testicular torsion, ovarian torsion, round ligament syndrome, epididymitis, and other non-descript gastroenterological issues. What I won't tell you, acute appendicitis, it is a monkey of disease. All of this disease can show us in the patient like appendicitis, but it will be not appendicitis. Obtaining a detailed past medical history and performing a problem-oriented physical examination is necessary to class the differential diagnosis. Accordingly, recent viral infection mainly suggest acute mesenteric adenitis and rising cervical motion tenderness. During transvaginal physical examinations, typically present in the pelvic inflammatory disease. One of the challenging differential diagnoses is an acute presentation of Crohn's disease. While a positive past medical history of Crohn's disease can prevent unnecessary surgical procedures, Crohn's disease might acutely present for the first time, mimicking acute appendicitis. Intraoperatively, the presence of inflamed ileum should raise the suspicion of Crohn's disease along with other bacterial causes of acute ileitis, including Yersinia or Campylobacter ileitis. The preferred approach is to proceed with an appendectomy, even if there is no evidence of acute appendicitis. However, in patients with features of ileitis along with inflamed cecum, the appendectomy is contraindicated as it would be later complicated. Complication. Postoperative abscess, hematomas, and wound complications are all complications that can be seen after appendectomies. If the wound doesn't get infected, one may grow bacteroids. Recurrent or stump appendicitis can occur if too much of the appendiceal stump is left after an appendectomy. In my practice, the most hard situation was with complication after surgery, and I have one patient with abscess. It led to big operation after we need to delete him a big part of the colon. Now he is invalid. Hard to understand why it's happened, but sometimes I think that it is my fault. About hematomas, I have 10 patients with hematomas after surgery. And what you need to know, always when we do something, you need to understand that you will have complications every time. Don't worry about the complications. Understand that just complications will do you a big surgery. This acts just like an appendix and can become occluded and infected just as with the initial episode. Therefore, it is important to ensure that there be very minimal and preferable less than 0.5 cm appendical stems after an appendectomy. If left untreated, appendicitis can lead to abscess formation with the development of an enterocutaneous fistula. Diffuse peritonitis and sepsis can also develop, which may progress to significant morbidity and possible death. Postoperative and rehabilitation care. Patients with uncomplicated appendicitis will generally experience an unavoidable postoperative period, and postoperative antibiotic therapy is not required. However, the group of patients with complicated appendicitis should be planned for antibiotic therapy for an average of 4 days. Wound complications, including infections, should be managed and adequate wound opening and irrigation followed by packing. However, antibiotic therapy is essential in the management of patients who are complicated with abscess formation and deep facial plane involvement. Thanks for your attention, guys, and downstairs you will find a few links to video on YouTube, my video with surgery, with palpation, surgery, palpations, and I think that's all what I will show you. And I pleased you. In these lectures, you don't see classification of acute appendicitis, you don't see a complication of acute appendicitis, and you don't see these scores. You need to prepare it in your home task. Be careful and have a nice day. Bye bye.